My name again is Rohan Ramakrishna. I'm a neurosurgeon at Weill Cornell Medical Center and New York Presbyterian Hospital here in New York City. I treat patients exclusively with brain tumors, and patients with glioblastoma tend to be a very large part of my practice. I went to medical school at the University of Pennsylvania, and then did my neurosurgical residency at the University of Washington in Seattle, followed by a neurosurgical oncology fellowship at MD Anderson in Texas, and then came to New York to start up my practice here at Cornell. In terms of research, I spend most of my time doing research related to glioblastoma, and I'm very interested and have performed clinical trials in that space. And so some of the clinical trials we've done have been sort of national clinical trials, like the Tokagen trial, which you may have heard of, or another trial from the MD Anderson group using oncolytic viruses for glioblastoma. I'm currently developing a few new protocols for patients with gliomas. So I hope those get funded and can take off in the next, several months. But that is generally my practice, and it's very rewarding. It's been great to take care of patients with gliomas and guide them through what is often a very difficult process.
Great, thank you. So let's go ahead and I have a series of questions that people submitted on our social media or that the OurBrainBank staff came up with. And my first question is especially relevant to us right now because I think many of you know our founder, Jessica Morris, is undergoing surgery. It was supposed to be yesterday, and then it was supposed to be today. Now it's going to be tomorrow. But it's the kind of surgery where she'll be awake the whole time. So we all are wishing her the best and hope everything comes out. Can you talk about that type of surgery? What's the technical name? How long does it take? How you do the anesthesia? That kind of thing?
Sure. Awake craniotomies are an important, critical part of the neurosurgical armamentarium when it comes to removing brain tumors in areas near, especially speech parts of the brain. And so the main way we do that procedure is the patient comes to the operating room, they get some twilight anesthesia, so they're not asleep enough to require intubation or a breathing tube. They're able to breathe on their own, but asleep enough where they're not very aware of what's going on. And once that's started, that conscious sedation, we numb up the scalp in the area where we do the operation. And then we can actually do the cutting and all that other stuff with the conscious sedation on board, as well as the local anesthetic that we put in the scalp. And so once we've exposed the part of the brain that is required to do the operation, we wake up the patient from the anesthesia, the conscious sedation. And initially they're a bit groggy, but in a matter of minutes, they're back to being, awake and articulate. And then we start mapping the brain. And so what that means is we have a neuropsychologist sitting in front of the patient, and the patient goes through a series of language tasks where they're asked to name the pictures they see in front of them. They're asked to repeat things. They're asked to speak, in normal conversation. And in the midst of all that, we'll be stimulating the brain with an electrical probe. This is, interestingly, a very old technique. This is not something very modern, but this was invented, nearly 60 years ago. It's been refined subsequently, but it's been, a very important part of neurosurgical care for a long time. And so when we stimulate the brain, when someone's talking, if it's an important part of the brain that's related to speech function, the patient will stop the speech task that they're doing, or will not be able to do it properly, or will make errors in their speech. And so when we find those areas, we put little tickets on the brain and mark them so that we know that those areas are no-go areas. And then once we've mapped the brain, we can be fairly confident of where the important areas for language are located. And then we start the tumor removal part. And during the tumor removal part, we keep the patient talking and interacting. just to have that extra bit of feedback while we're removing the tumor that their language function will remain intact. Once the tumor is out, we put the patients back to sleep into this conscious sedation, twilight anesthesia type state. And then we put everything back together, put the bone back, close the scalp, and then we wake them up again and they go into the recovery area. In terms of the length of the procedure, it's on average, I would say 4 to 5 hours from start to finish. Sometimes a little shorter, sometimes a little bit longer, but that's about the average. And I would say patients, I wouldn't say they want to do it again, but they're pleasantly surprised with the, effective or the experience of the operation, I should say, given the, preoperative anxiety about having an awake operation. I think most people post-operatively feel relatively calmed by the experience.
Wow, that's amazing. I would think it would be profoundly strange, but I guess it's worth it, right? Can you talk about the benefits? I mean, do you see a benefit during the actual operation itself, or does the brain need to heal for a while afterwards?
So the reason we do awake operations is because for 2 reasons. One, we want to do our best to preserve and hopefully improve language function to the extent it's affected from the tumor. And the only way you can do that is by knowing where everything is located in the brain. And it's variable from person to person. So that's why the mapping is so important. The second reason is if we know where everything is, we can be as aggressive as possible in the removal of the tumor. If you don't know where everything is, you can make, 2 different types of errors. One, you can take out too much of the tumor in the surrounding areas, which can cause permanent speech problems, or you cannot remove enough because you're, hesitant about causing a speech problem. So our goal is to really affect and go for a gross total resection of these tumors during the operation, because these are, it's a big procedure to have a brain operation. So we don't want to, we want to make sure that the operation is as effective as it can be, so that patients can have the best responses to the chemotherapy and radiation. And we know that gross total resections are associated with better long-term outcomes.
Wow, really interesting.
Can I ask a question? My wife had awake surgery here in the UK in Oxford, and one of the things they were anxious to map during that operation was ability to identify human emotions. So it wasn't just a question of speech. She was shown pictures of faces and was asked to identify what emotion she thought that person was betraying in their facial expression. So it seems that it's used to map the impact on a whole series of brain functions as well as speech.
That's absolutely true. There's lots of things you can map with awake surgery. I mentioned speech and concentrated on that because that's the most common. But from the standpoint, we can map motor function, like movement. You don't have to be awake for that, but we do map that part of the brain for that purpose. And there's lots of other subtle things like recognition of faces or emotions that you can map. Now, the interesting thing is some of those more subtle mapping techniques, there tends to be some redundancy in the brain. So, for example, there's a part on the basal part of the temporal lobe where if you stimulate, people stop talking, but it's not really critical towards speech arrest or towards speech function. And so you can remove that area, even though in the operation, the person will not be able to talk if you stimulate that area. That's just something that's been gleaned from hard-won experience over many decades. But when it comes to the recognition of faces and emotions, the good news is there tends to be some redundancy in that. I have yet to find again, the basal part of the temporal lobe, people tend to say that is associated with emotional recognition, facial recognition. But, I have not tended to see that as a permanent problem in patients in whom we remove or do large temporal lobe resections. In fact, I can't think of anyone who's had that particular problem, where after the surgery, they've been unable to recognize faces. There's this thing called Capgras syndrome where people, it's associated with strokes in a certain part of the temporal lobe, where they'll see someone they should recognize like their mother, but think it's an imposter rather than their actual mother. So these are bizarre syndromes that we still don't quite understand. But the bottom line is, in terms of mapping, when I think of mapping, you really want to map those functions that don't have redundancy in the brain, and make sure that those are preserved, because those other quote unquote subtle things often have some built-in redundancy in the brain.
Thank you. That's fascinating. What?
Ask a question to
Yeah.
in regard to that. Hi, Dr. Ramakrishna. So you mentioned that at initial detection of the tumors, yes, awake craniotomy is done, but at recurrence, is it a common process to be done if the tumor comes back at the same spot of the language area, and to do awake craniotomies, or the second, third time around, you guys prefer not to do it and it's not recommended, or it's treated the same way as new glioblastoma?
It's hard to give a blanket answer to that. If the tumor is close to speech cortex and the tumors recurred near that area, I would still be most comfortable if I did an awake surgery again. Sometimes you don't have to remap even if it's close to speech cortex, because it recurs within the cavity, the hole in the brain where it used to be. So we have to make very individualized decisions from person to person based on our experience with the first operation, where the tumor has recurred, their ability to tolerate an awake operation, their baseline language function. If their language is unfortunately poor, then it's very hard to map, because you don't know if, when you're stimulating, whether the problems are related to the stimulation or related to just their baseline language dysfunction. So we have to make a very individualized assessment for each person on whether or not they need a surgery in the first place, whether awake surgery is the right thing. And we make that determination at least in our center, and it should be this way at all places, in a very multidisciplinary way with our neuro-oncologists and radiation oncologists, and really the whole team taking care of the patient.
Thank you.
So you brought up earlier clinical trials, and usually I think most people, when they think clinical trial, they think it's testing a drug or a device, and that surgery wouldn't be as important. So could you talk about that a little bit, please?
Yeah, so clinical trials are critical for glioblastoma and for all cancers generally. I don't have to tell this group that, glioblastoma remains a serious illness with almost certain impacts on length and quality of life for those who get diagnosed with it. And so we have a fairly, well-studied regimen for patients who are newly diagnosed with glioblastoma. It's still not good enough because it's not a cure. And in the recurrent setting, we have even less, I would say, robust options. We have lots of options, but in terms of things that provide reliable long-term benefits for patients, we still don't have that, as you all know. So the clinical trials, they're used to study a range of things. In glioblastoma, it's often, the effects of new drugs or small molecules or viruses that may have an impact on lengthening life and producing and causing the tumor to revert. That's our goal with these clinical trials, is to find more effective therapies than the ones we have now. And there are clinical trials specifically related to radiation therapy or related to surgery. But in terms of, glioblastoma, while surgery is critically important to manage the disease, it's not a surgical disease, if that makes sense. And I say this as a neurosurgeon, knowing that I can't cure glioblastoma with surgery, right? And no one should no one should believe that if others mention that, because as you know, these gliomas grow by infiltrating through the brain. And so we can't remove all those cells because they're dispersed within normal brain, and we can't neurologically hurt people or we would neurologically hurt people if we tried to remove all those infiltrating cells. And so the purpose of our adjuvant therapies, like our chemotherapies and radiation, is to treat those infiltrating cells. And our clinical trials are often nowadays looking at some of these adjuvant therapies, which are often drugs or viruses or other biologics, to see if we can arrest the growth of the tumor and even better, make it go away.
Great. Yeah, our Jessica Morris, our founder, she had she's on the trial where she had the herpes vaccine injected into her tumor. Are you working with any virus immunology? And actually, while anyone can ask a question, I have a list here, but everyone is welcome to jump in. You can either do it in the chat or unmute yourself and ask.
So yeah, we've done a virus trial in recurrent glioblastoma. It closed to accrual last year, and that was using a modified adenovirus, which is sort of related to the common cold, to help to treat recurrent glioblastoma. And the way it works, we think, is by two mechanisms. One, it infects tumor cells and theoretically can help stop replication. But two, it also induces an immune response. And so when you generate an immune response in the area of the tumor, sometimes in some patients, you could see the immune cells attack the tumor and get rid of it. And for that reason, this virus was combined in the particular trial we ran with pembrolizumab, which is a checkpoint inhibitor, quote unquote, immunotherapy. And so, I think, to cut to the chase, is it a cure? No. But did we see some patients with good responses? Absolutely. And so there are other oncolytic viral therapies like the herpes virus that you just mentioned, and a number of other centers throughout the world which are working on oncolytic viral therapy. And, with all these viral therapies, we see patients who sometimes respond really well to it. And so part of our work is to figure out why are those patients responding well to it? What makes them responders versus not responding? And figuring out how we can tweak the viruses so that they're more effective in more people. So no clear answers on that yet, but lots of people are working really hard to figure that out.
And what are some of the factors that do cause it to be so difficult to treat? I know, because it seems like each person's GBM is different and their body responds differently. Are you seeing, what kind of patterns do you see?
Well, GBMs are very genomically diverse, even within the same tumor. So one way of thinking about it is no GBM tumor cell in your own GBM is exactly the same. And for GBM, that's critically related to the fact of why it's so resistant to therapies. Because if you think of a tumor undergoing evolution in real time, because we're giving it therapies that are supposed to kill it. So they have a lot of genomic diversity in these tumors. And because they're so diverse, they can find mechanisms to escape, the toxicity of the drugs we're giving. So that's why they're so resistant, even within a single person's own tumor. And then if you look at across people, their tumors are very different too. Although we have these ways of categorizing them and putting them in particular buckets, they're still very different from person to person. And that makes it really challenging to figure out what's going to work in any one individual patient. And on top of it, to me anyway, this is my opinion, I think that makes single agent therapies, whatever they are, much less likely to be effective in a tumor like GBM, meaning that if we just give one drug targeting one antigen, like EGFR as an example, what we've found with those kinds of therapies is that the tumor clones that express EGFR go away, but the tumor repopulates using tumor cells that don't have that particular antigen. So, we have to come up with better, quote unquote, multi-pronged strategies that attack the tumor from multiple angles. And there's lots of work, looking and thinking about that going on.
I had a question. Is there any chance that since these tumors are so diverse, is there any chance that the part of the tumor that they're testing in pathology could be misdiagnosed, could not be a true, picture of really the entire tumor, since there's different areas or different things involved?
It's a good question. It's typically with gliomas, when we do a biopsy, that the main issue is making sure we can diagnose it correctly from the standpoint of grading, like whether it's lower grade or high grade.
Mm-hmm.
And the smaller the sample, the more likely it is potentially that you'll not make, you'll get the grade of the tumor wrong.
Mm-hmm.
Or that if it's a really small sample, that you miss the tumor during the operation. Thankfully, that's pretty rare with needle biopsies, but still it can happen where we don't get a good diagnosis from the operation.
Mm-hmm.
Because there's not enough tumor cells in the sample. And then more commonly what can happen is the tumor cell is not graded appropriately because the sample is small. And so instead of it being diagnosed as glioblastoma, maybe it's anaplastic astrocytoma or a lower grade tumor.
Mm-hmm.
Or something like that. The more sample you have, the more ability you have to be confident that your diagnosis is correct. So we take great pains here to make sure that people get, the pathologists get good quality biopsies to prevent misdiagnosis. But misdiagnosis in terms of classifying a glioma as something other than a glioma is pretty rare. We're good at, and pathologists are good at diagnosing gliomas, but it's really a matter of having enough tissue to do all the stains that they need so that they can categorize the tumor appropriately. And the more tissue you have, the better ability you have to do all the stains you need, get all the genomics you need, et cetera. So that's why we take great pains to make sure everyone gets a reasonable amount of tissue removed during biopsies for the pathologist to examine.
Mm-hmm.
Can I ask a question related to the heterogeneity of glioblastoma? It seems to me that in this country, under standard of care, it's not.
Sorry, I've lost you on. You're muted. I think Richard.
Sorry, I thought I'd unmuted. So the question was again related to the heterogeneity of glioblastomas. In the UK, under standard of care, it's not usual.
Richard, I'm sorry. If you can hear me, I still can't hear you. Are the other people hearing? I've lost all audio.
I can hear him.
1 second.
I'll try talking again. So it was a question related. Can you hear me now? No, I don't think so. I'll duck out then. I'll leave it if Dr. Ramakrishna can't hear me. I'll leave my question.
I can hear you now. Can you hear me now?
Yes, I can hear you well.
Okay, sure. I can hear you.
So it was a question related to the heterogeneity of glioblastoma. In the UK, under standard of care, it's genetic analysis of the tumor is not usually done. And you talked about trials, and you talked about the fact that there's this great diversity in the tumors. It seems to me that there must be a problem in trials if you're not doing a genetic analysis of the tumor, knowing whether a treatment may be effective. I mean, you talked about a drug that might target EGFR or checkpoint inhibitors that might target particular mutations. It seems to me that unless there's a knowledge of what the genetic makeup is of the tumor, that trials are not necessarily going to be that good at evaluating the effectiveness of a treatment. Because they're being applied in a blanket way across a great variety of mutations.
Yeah, it's a good point. I mean, I think a lot of newer trials are enrolling patients based on molecular attributes that don't require, genome sequencing. You can make very good inferences about the genomic makeup of tumors from the variety of histochemical stains that we perform in the pathology laboratory, like IDH or EGFR, et cetera, and use that to enroll patients. And additionally, there are now more targeted genomic panels that look at an array of cancer-associated genes, which you can perform at reasonably low cost. That, again, it's a targeted panel. It's not the whole genome. But that information can be used, again, to enroll patients in trials based on genomic signatures or certain mutations or deletions or amplifications. There are a number of trials now that aren't even specific to GBM. They're called solid tumor trials, which includes any solid tumor cancer, where you're enrolled based on some of these genomic factors that I mentioned. So, I recently reviewed a protocol where it didn't matter what your tumor was. If you had a certain genetic signature, you'd be able to be enrolled in this trial. So, I do think that more of those trials are coming down the pike, and these kinds of genomic tests will be required to help enroll people. What the effects of some of these very targeted agents are on the variety of cancers they're aiming to treat is yet to be seen. I think we can expect that the effects are not going to be the same across the different cancers, despite similar genetic signatures that they use to enroll the patients. And then the last thing I'll add is, in terms of genome sequencing, people ask about it a lot. The unfortunate fact in 2020 is that we get a lot more information from the sequencing than we necessarily have drugs to deal with it. So being an amazing quantity of information from gene sequencing, but we don't necessarily have drugs that target every mutation or pathway that we identify as aberrant on a genome sequencing panel. And drug makers and academic labs throughout the world are really thinking about, how they can use this genomic information to design therapies that attack affected pathways in those tumor cells, yet keep normal healthy cells, intact. So that's where everyone's working furiously to make a difference. And, I'm hopeful that we'll continue to see progress, not just in GBM, but across all these cancers.
When you say, I was curious, when you say the geosequencing, are you referring to like the test they do at Foundation One in Boston?
Yeah, that's a type of gene sequencing platform.
Okay.
But lots of centers, like our center, we do our sequencing in our own hospital. We don't. We do send occasionally patients for foundation testing, but we also have our own precision medicine center at Cornell that does whole exome sequencing and RNA. I mean, a lot of this is research, but we do that here.
Could you tell us about the Rhodes Center for GBM? Are you involved with that?
Yeah, so the Rhodes Center is a collaborative effort between Cornell and Columbia here in New York City. And it was founded because of a generous gift from Bill Rhodes, whose wife had glioblastoma. And basically the goal of this is to advance innovative therapies for glioblastoma. And so it's really primarily designed for funding research, innovative path-breaking type of research on both of our campuses, and encouraging people who do research in other cancers or in other related fields to think about glioblastoma and fund, interesting new concepts or ideas, collaborative ideas, where, you need some pilot data before you can go on to more robust federal funding, things like that. So to give people a jump start at these sometimes high risk, high reward concepts with a real focus on collaboration and bringing people who aren't necessarily thinking about glioblastoma into our world to, you know, take advantage of their expertise. So our first set of, we had our first grant cycle for that, and we are in the middle of reviewing the grants, and we should be making our announcements in the next 2 months or so about which groups at Cornell and Columbia got funded.
Great, thank you.
I have a question. So how do you involve patients and families in their treatment? Our Brain Bank is all about empowering patients, and do you encourage them to get a second opinion, or what's the process?
Yeah, I always encourage patients to come with their families to their visits. I find that the relay of information, if it's just one person to the family, is often incomplete and sometimes even wrong. You know, understandably, when you're hearing all this in the space of a 30-minute visit or 45-minute visit, it's easy to misremember or relay the information inaccurately. You know, when you're dealing with the anxiety of your own diagnosis. And so I always encourage family members to be present if that's appropriate for each person, number one. And number two, it's always a collaborative effort between, you know, me, the doctor, and you know, you, the patient, and the family. I think of us as co-captains in terms of making decisions. And we have to make decisions not just about how to most effectively treat your tumor surgically, but what's the best treatment option in terms of quality of life, your wishes about the kind of life and quality you want to have as you're undergoing treatment, what risks you're willing to accept, you know, those sorts of things. And so that's why it's a very individualized discussion with every patient about, you know, what the most effective therapy will be for them. Sometimes it's no therapy. Sometimes it's very aggressive therapy. So, you know, and everything in between.
To that point, if I don't mind me asking, so then do you also, are you one of those oncologists who's a proponent of, besides standard of care and clinical trials, also encourative to the patient of trying out, you know, cocktail drugs, so-called, what we hear and read a lot about in terms of repurposing other drugs for the cancers, you know, towards GBM. Yes, we know there's nothing that is proven to be curable and whatnot, but it's more like, hey, try a few more things and see what sticks and improve survival or pushes things out.
Yeah, I mean, I think in our group, we're very thoughtful about the kinds of therapies we offer. I mean, we don't just throw darts at the wall and see what happens. I think we, you know, our oncologists, you know, look at the genomic information, look at the patient sitting in front of them, and think about what strategy is going to be potentially most effective based on that kind of information and least toxic, while hopefully maintaining, while hopefully being, again, effective for the tumor and also effective at maintaining a good quality of life. And that's what I mean when I say thoughtfulness, is really kind of understanding the genetic program of that tumor as it's, you know, understood from the sequencing data that we have, and then trying strategies that may be relevant for that particular tumor, either through drug repurposing, like you mentioned, through you know, standard drugs that we have in our toolbox, and then through clinical trials, either at our center or at, you know, neighboring centers, either in the city or even nationally.
What's your opinion? I know many in our community, and including Jessica, wore the Optune device or are wearing it. What's your opinion about Optune?
Well, you know, I think it's part of the toolbox for patients with glioblastoma. I mean, there have been good quality randomized controlled trials showing that Optune does have a benefit. You know, again, is it a cure for GBM? No. And the studies don't say that, but in terms of providing improvements in tumor control and progression-free survival, I do think that the evidence suggests that it is effective. whether it's effective for any individual patient is a discussion to be had, again, with their oncologist. And you know, how that device potentially can be combined with other therapies is an area of ongoing investigation, which is really interesting.
When you say how it can be combined with other therapies, what kinds of things are being looked at? My wife is wearing the Optune device, but and we are trying other therapies. But I'm just intrigued to know what kind of research or what kind of thought there is about that.
You know, the trouble, I say that sort of as an academic interest. It's unclear to me with a lot of the new drugs, for example, you have to prove that they have an effect on some level before you can start combining it with other things, right? So I'm not aware of any particular trial of, right? I'm sure there are, but I haven't looked recently about combining Optune with other immunotherapies or cytotoxic chemotherapies or things like that to see if it can enhance its effectiveness.
What do you classify as a newer drug? I'm curious.
Well, I mean, there's like these things called CDK inhibitors. There's a number of trial drugs that are in different phases of clinical trials.
Right.
These viral therapies that we talked about earlier, they're all being studied. And again, we can't really comment on the effectiveness of it because they're all in the trial phases.
Mm-hmm.
What do you see as the most promising new treatment that might be on the horizon that people aren't using yet, but is there anything new that's just beginning that you think is very promising?
You know, I think the oncolytic viral therapy is very interesting. We're continuing to pursue that, and you know, I think we will find a niche for that in patients.
Wait,
eventually.
sorry, I didn't catch what was that? Say that slowly, please.
I think we will find a niche for oncolytic viral therapy in the future. So I am optimistic about that being effective in certain patients once we have more data. In terms of other therapies, I think immunomodulation is another area that I'm fascinated with. You know, springboarding off of our experience in oncolytic viral therapy, the patients who tend to respond to the therapy have a robust immune response in the area of the tumor that we can see on MRI scans and in pathologic specimens when we remove it. And wondering whether you can generate that kind of immune response without injecting the virus necessarily. Can you use drugs or radiation strategies or things like that to replicate that without having to inject a virus? So those are areas that I'm looking at into, others are looking into similar areas to see whether we can make cold tumors means tumors that don't have much immune cells in them, into hot tumors where they have lots of immune cells and where immunotherapies might be effective. So, you know, I find those kinds of research pathways to be very interesting. And then, you know, we'll see what these other trials that are looking at trying drugs based on certain genomic signatures, how they fare in patients with gliomas. I'm hopeful that we'll identify some anyway that have a robust response.
Great, thank you. How do you feel about, do your patients do, I don't know if you want to call them supplemental therapies, such as herbs, medical marijuana, things like that? Do you encourage that? Do you discourage that? Is it a case-by-case basis?
You know, you want to be as scientifically responsible with your recommendations as possible. So I don't necessarily have any issue with complementary therapies. But on the other hand, I'm not often asked about it in the sense as the surgeon. I get asked a handful of times a year, but the people who get really asked about that a lot are the neuro-oncologists prescribing the chemotherapies. And I think just a responsible person would say, those things are probably fine, but we have to monitor how they interact with the drugs that you're taking and make sure that they don't cause any, toxic side effects. So that's kind of first rule of medicine is, first do no harm. And, you want to make sure that you're not just, patients are not on a unproven cocktail of things that you can't really monitor either for efficacy or for toxicity, especially when they're potentially interacting with the chemotherapies that people may be on. Some of these drugs have a side effect of thinning your blood, which can make bleeding in the brain more common. So we just have to be careful about all of that. But in general, I don't have any particular issue with anything. I think if patients want to try it, it's worth trying. But I should just add, they should do that under the guidance of their physicians. Important that that's not done, without their knowledge.
Does anyone have any other questions? So what
Yeah.
do you,
Sorry.
go ahead.
Yeah, in terms of for recurrence, right? I mean, how do you advise folks like us, caregivers, to research? I know we have oncologists and whatnot to talk to, but a lot of times the options of surgery, just surgical advice in terms of gamma knife versus gamma tile that is now started versus just plain surgery, I know it all depends on where the tumor is, where the recurrence is and whatnot, but assuming the recurrence just happens in the same resection cavity as the previous time, is there like a standard protocol there? Or sometimes it's hard for a caregiver to make those kind of decisions. So is there some kind of some advice you have there?
Yeah, I mean, I don't know that there's a blanket guidance I can give you. I think what I would say is that, you're on call, as we do here, your oncologist should be, hopefully plugged in or knowledgeable about clinical trials or other therapeutic options that are available, not just at your own center, but at, places nearby or regionally that you may have access to, and can guide you to, people who would provide valuable second opinions. So I always think second opinions are great, especially if you're getting them from, noted experts in the treatment of this disease. So I encourage those. I do caution you against getting 1,000 opinions, because then you'll be paralyzed by indecision about what to do. So you want to be judicious, but get multiple opinions and to the extent that it gives you a good basis of foundation of information and options. Because that's the point, is to know what your options are when you get multiple opinions. And so I do encourage it. So that's what I would say, is that, when you're dealing with recurrence, talk to your oncologist, but then, if you're looking for more options, try a different center or get a second opinion.
And a subsequent question to that, thank you, doctor, is that we hear a lot about, storing the tumor in the live format, not in the typical frozen format that's saved, right? But there are some companies that advertise that, market that. And for glioblastoma, I know some hospitals do it. A lot of hospitals don't do it during surgery by default. Yeah. And so is that a consideration you think that should be high priority for the patient to say, hey, we have the option to ask our surgeon to store the tumor in the live format? Or is that something that is really no ROI in? What's your opinion on that?
Yeah, so growing live cultures of tumors is, to assess, multiple drug options in real time and then give that information back to the patient is something that we're working on here, and others are as well. Is that prime time yet? No. So I don't think you should necessarily think of that as, a key thing in determining, what treatments or what academic centers or physicians to access care. I mean, if they're doing that kind of high quality, high complexity research, it just tells you that they're very interested and motivated, to take care of patients with gliomas, which is good. but in the sense of providing, at least in 2020, immediate, real-time, proven, efficacious feedback from these live cultures, we're not there quite yet. But I'm hopeful that, I don't know what the time frame will be, but in the near future, that we will be able to deploy, that kind of real-time information to patients using live cultures. But people are working to try and figure out similar information using, genomic information, artificial intelligence and genomics to figure out how someone's genetics will inform their response to certain chemotherapies or immunotherapies or targeted agents, and then make inferences on what drugs to then give them. And we're working on a trial that does just that in the next several months.
But so yeah, fair enough that we don't have this in real time. We can't give the data based on the information from the tumor. But is it not by default, shouldn't the patient, just to be on the safer side, just save the tumor, ask for the tumor to be saved in the live format, and if something comes out of it a year from now, fair enough, he at least has his live tumor to get that data? You know what I mean?
Well, first of all, that's not wide. Saving tumors in organoids or live cell cultures is not a standard thing by any means. It's only done in a handful of places, honestly, throughout the world. So even if you request it, it's probably not possible in most places. Secondly, a lot of tumors don't grow in the lab. So it's not necessarily the case that if you just take a tumor and put it in a petri dish or in an animal, like what's called a PDX, that it's going to grow necessarily. A lot of them do, a lot of them don't. Particularly in recurrent tumors, it can be harder to grow them in the lab. So, the science behind growing these is not 100% figured out in terms of making sure that we can always grow these cells in the lab. To your question about storing it in live culture indefinitely, that presents a lot of practical issues, which I won't get into, but if you could imagine lots of patients, and we're not really doing anything other than just, because if you grow them in an animal, let's say, eventually the tumor will kill the animal, so then you have to replant the tumor into a different animal, and then how long do you keep doing that, right? So if you don't have a proven way of figuring out what you're going to do with that what we call PDX or live cell culture. So, I think it's not quite ready for prime time, at least in glioblastoma. It needs to be studied more, but I think it will be important. But in terms of telling you that you need to store your tumor for live culture, or your loved one's tumor for live culture indefinitely, I can't recommend that yet.
Thank you.
Well, we're coming up on 1 hour. For those of you who joined late, I'm Martha. I'm a staff member of OurBrainBank, and I don't have GBM myself, but our founder, Jessica Morris, is living with it more than 4 years now. And I want to thank you, Dr. Ramakrishna. This was absolutely amazing, and you explained so many things, and it's so interesting, and we're also grateful for you taking your time. We know your time is extremely valuable. Before we go, I want to plug the OurBrainBank app. I think most of you are familiar with it. Go on the App Store or Google Play. We're only ethics approved for the US and UK, although we hope to launch in other countries as we get funding. And I'd also like to plug two of our advocacy partners. One is the Brain Donor Project, where you sign up, and anyone can do it, whether you're healthy or living with GBM, anyone in the US can do it. And you sign up, and then after death, your brain is donated for research, and they are studying GBM using this tissue, and it's incredibly important. Anyone can do it, it's free, and you can sign up. There's another group called the Brain Cancer Project, and they have Count Me In, where they are asking for samples of genetic material, blood or saliva, and they're building a bank of brain cancer patients. And so that also to help researchers. Any last questions for Dr. Ramakrishna?
Any trial right now in Cornell and the places out there which you all are doing in collaboration with other places? Like because of COVID, I'm sure there's a lot of people can't fly down to different places to have a trial of their choice, right? But if they choose something there, is that something you guys are willing to collaborate in hospitals in the US, at least some of them, to also do it, distantly?
We don't, I'm trying to think. I mean, some of our trials, none of our trials have any COVID relationship to them in terms of being activated because of COVID. We have a number of trials. I encourage you to go to our the Meyer Cancer Center at Cornell website to see the actual listing of them. So because I don't want to forget any of them. But they deal with different targeted agents. Some of them, again, are related on mutational profiles, so they aren't necessarily specific to glioblastoma. It's any tumor that in any part of the body that has certain mutations. So some of those are not quite open yet, but they'll be open in the next couple of weeks. If you're interested in discussing the options, if you're in the New York area or anywhere really, definitely reach out to our neuro-oncologists. Their names are Howard Fine and Rajiv Magge, M-A-G-G-E. And, especially if you're even if you're in the city, but even if you're not, you can have video visits now since we're really ramping up telemedicine. So you don't have to come in, but you can still get that information.
Yeah, by information is one thing. What I meant is if you have to do the infusion, for example, and you can't fly a lot to New York, say from Seattle where I am, then is there any provision being done across the hospitals like, hey, we are opening
Good
up?
question. Unfortunately, as of today, we don't have the ability of conducting a trial, but then doing the infusion in a different state.
Right.
Forget, a different part of the city. So, unfortunately, it's a good point. But there's some practical, legal, and logistical hurdles to that.
Okay. Thank you.
So in our community on, which is mostly on social media and these chats, we get most of our communities here in the US, but we get inquiries from all over the world. And then I just hear these things that I just can't even believe. His sister in India has GBM, and he said that there were no clinical trials in all of India, which I find very hard to believe. And then, so if they want to do anything, they have to travel, which of course is very difficult now. What would your advice be to someone who's outside the US or UK? And then can't afford to travel? Is there any options? What can they do?
I think the best options are you need to travel to the biggest center in your area that treats patients with brain tumors, because they'll have the most up-to-date information about what trials potentially are available in their country that are worth pursuing for the patient. So, unfortunately, a lot of these trials are particularly in developing countries, are not performed, which is unfortunate. But I think the best thing you could do is just establish a relationship with someone who's an expert, who doesn't just dabble in gliomas or glioblastomas, but someone who sees a lot of patients, and so therefore has, access to the literature and access to the information about where some of these trials might be conducted in their home country, if at all. So that, they can provide patients with some options.
Okay, thank you. Any last questions? Okay, well, I wanted to thank you again, Dr. Ramakrishna. This is really, really interesting. And I think this is the biggest turnout we've ever had for one of our chats. So you consider that a compliment. And I hope everyone stay in touch with Our Brain Bank. You can join us in our Facebook group, Instagram, or on Twitter, or on LinkedIn if you want to join us there. And we have our website, OurBrainBank.org. The nonprofits I mentioned before are advocacy partners. If you scroll all the way down to the page, you'll see their logos. and I encourage you to support them and join us. We've been doing these calls weekly during, we started doing it weekly during COVID. I'm not sure if we're going to stay or not, we'll see. But thank you to everyone, and especially Dr. Ramakrishna. And I hope this was informative, and learn more about our brain bank at OurBrainBank.org. Okay, I'm gonna say goodbye.
Thank you.
Thank you.